Welcome back to part 2 of chapter 12, and we're going to get started on pyelonephritis, which is an upper urinary tract infection, and it is considered an infection within the renal pelvis, the tubules, or the interstitial tissue. It can affect one or both sides, and it can be an acute infection, which is an ascending affection from the bladder, or it can be chronic, which has no specific explanation. There are several predisposing factors to pyelonephritis, such as anatomical abnormalities, such as a uterovesicular reflux, urinary obstruction, stress incontinence, multiple UTIs, trauma to the kidney, renal disease, metabolic disorders, and pregnancy. So let's talk a little bit about the pathophysiology, and it's typically caused by fecal flora that colonizes in the vagina and subsequently ascends along the urinary tract to the kidneys. The bacteria is believed to enter the urethra and ascend towards one or both kidneys via the uterus, the bloodstream, or the lymphatic system. And in acute pyelonephritis, you can have swelling of the renal parenchyma, which occurs as a result of the infectious process. These infections can be life-threatening in our older folks, kids, and anyone that is immunocompromised. Also, UTIs are associated with premature deliveries, so it's important to treat our pregnant moms if they present with these symptoms. And then chronic pyelonephritis is usually caused by the recurrence of bacterial infections in the kidney, often related to those individuals that have catheters. On acute pyelonephritis for clinical presentation, they may be suddenly sick with an onset of fever, shaking, chills, nausea, vomiting, pain, fatigue, diarrhea. Otherwise, they may be asymptomatic. Elderly patients may present with altered mentation, and in a chronic presentation, you may see nausea, decreased appetite, weight loss, increased voiding at nighttime, and polyuria for symptoms of renal disease or renal failure. Management of these folks includes decreasing the symptoms, decreasing reoccurrence, I think we went over this, decreasing the concentration of the substance, and in pushing fluids. Pain management is important. Prescribing NSAIDs at 600 to 800 milligrams, that should say 3 times a day. Oral narcotics may be necessary. NSAIDs can also relax the ureteral smooth muscle, which can help with the stone passage. Antispasmodics may help with temporary relief, but can lead to urinary retention. Warm compresses, focused imagery, focused breathing, diversional activities. Another medication that they are not mentioning, and I'm not seeing it on future slides, that I have found that has been helpful with stones is Flomax. Along with that, it helps relax the smooth muscle and often can help the stone to pass, and this can be used in both men and women. Other management might be non-invasive or invasive surgical procedures, lithotripsy to break it down. Ultrasonic lithotripter applies ultrasound waves to help break it down, and then a flexible ureteroscopy to take it out if the stone is larger than 10 millimeters. A lithotomy may need to be performed to remove it if no other means of getting it out is possible. And these are some of the other surgical procedures, and we've talked about the preventative measures. Most of these individuals can be treated on an outpatient basis, but need to be followed up in the office a day or two after, depending on how their symptoms are presenting. They also may need hospitalization if there's other issues that are going on. If you're needing to have a stone removed, you're going to need to refer to a urologist or nephrologist. Patient education is so important with this condition. They need to have increased fluid intake. They need to monitor their I's and O's and to assess for a passed stone. You will often send them home with a strainer that they can void into to see if there's a stone that is passed, and you may or may not want them to save that stone for you so it could be sent to pathology if you do not have a confirmed diagnosis of what type of stone it is. It's important that these folks avoid medications that contain phosphorus or calcium, and also vitamin D, as we know vitamin D helps in the uptake of calcium. And it's important to promote B6 and magnesium as they decrease the oxalate metabolism, which can lead to stones. Increasing activity as tolerated. Dietary modifications are important, and avoiding caffeine, beer, and wine, eliminating milk and cola products, and then limiting purine-rich foods, which we talked about. Next is renal tumors and bladder tumors. We're not going to go into the specifics of those, but I want you to review that in your book. And renal tumors start on page 622, and bladder tumors end on page 626. So review that. And let's talk a little bit next about acute kidney injury. So acute kidney injury is also known as acute renal failure, and it's a sudden change in the renal functioning, resulting in the inability to maintain a strong acid-base balance, fluid and electrolyte balance, and then you have an accumulation of nitrous waste, which can be toxic to the kidney. It may develop over days to weeks. It can be completely reversible, and the most common causes are associated with some type of intrarenal injury caused by renal hyperperfusion or nephrotoxins. So some of the risk factors are any problems that can cause decreased blood flow to the kidneys: anaphylactic shock, nephrotoxin substances, malignancies, sepsis, cardiac arrest, aneurysms, or liver cirrhosis. There are 3 different groups of injuries. There's your pre-renal azotemia, intrarenal azotemia, and postrenal azotemia. We'll talk briefly about them. In the pre-renal azotemia, so these are conditions that can lead to a decrease in renal perfusion, hypovolemia, vascular disease, decreased cardiac output, systemic vasodilation, renal vasoconstriction, impairment of the renal autoregulation of their blood flow. In intrarenal azotemia, it could be caused by anything that affects the renal parenchyma, and you can see those there. And then in the postrenal azotemia, This can be caused by any condition that leads to an obstruction of flow of the urine from the kidneys, such as ureteral obstructions, bladder neck obstructions, and urethral obstructions. And major causes include BPH, prostate or bladder cancers, and metastatic disease. We know that the majority of acute renal injuries can just happen naturally, and they make up about 50% of all cases. Most of these are considered after pre-renal and post-renal causes have been excluded. And the sites of injuries for intrinsic acute renal injury may be glomerula, the vasculature, or the interstitium and the tubules. Some complications of an acute kidney injury include intravascular volume overload, metabolic acidosis, anemia, hyperkalemia, and uremic syndrome. We are not going to go over the pathophysiology of these three different types of azotemias, but I encourage you to look in the book on page 628 and 629 for the patho of the three different types. So you have a patient that presents and you're concerned for acute kidney injury. Some of the most common symptoms that you may see are going to be secondary to the accumulation of the nephrotoxic metabolites. And so symptoms may include fatigue, malaise, nausea, vomiting, itching, mental status changes, especially in our older population, oliguria or anuria, and then fluid overload resulting in shortness of air or orthopnea. On clinical presentation, it's important to ask your patient about their history of drug use, surgery, traumas, or any recent infections, anything that might impact the functioning of the kidney. We know that there are 4 identified stages, and so it's initiating the stage is going to be based on how the kidney has been injured, if there's decreased urinary volume, anorexia, lethargy, nausea, headache, muscle cramps, and fatigue. On clinical presentation, the oliguric stage can last anywhere from 5 to 15 days. And during this time, renal repair has started. With the regeneration of tubular cells, the nephrons may become obstructed with the debris of inflammatory products. You may have decreased glomerular filtration. The longer this process continues, the poorer prognosis. During the diuretic stage, it's when the urinary output is greater than 400 milliliters per day and BUN begins to fall. In the recovery stage, it extends from the time the BUN is stable and urinary output becomes more normal to the day the patient returns to normal activity, and this can take anywhere up to 10 months. Some patients never recover and progress to more chronic renal failure. Objectively, your patient may present with orthostatic vital signs. Decreased skin turgor, distension of the jugular veins is important to assess to obtain information about the patient's fluid balance. If there's been fluid depletion, you may notice a pre-renal etiology. If we have overload, it may suggest the degree of renal impairment. If there's severe proteinuria, that can lead to generalized edema. And if you note abdominal bruits when auscultating the abdomen, it can suggest renovascular disease. Diagnostic tests include BUN and creatinine, which will establish the diagnosis of renal failure. It's important to assess electrolytes as they can be life-threatening as they develop secondary to renal disease. And then the presence of RBC suggests a vascular or glomerular lesion. We know that WBCs will be associated with infection. Elevation in your eosinophils is indicating an allergic interstitial nephritis due to renal toxic drugs. If your urine sodium tends to be less than 20 milliequivalents per liter, it's considered a pre-renal disease. And then urinary sodium values can typically be greater than 40 milliequivalents per liter in these conditions. Also, in these conditions, there's an inability to concentrate urine, and then urine is more highly concentrated in the pre-renal phase due to the secretion of ADH, and urine osmolarity is typically greater than 500 milliosmolarity per liter. There are several diagnostic tests that can be used to assess acute injury, but it's important to know where you as a practitioner think the injury has occurred. So if it's a glomerular process, you may want to order an ANA, an anti-neutrophil cystoplasmic antibody, an anti-glomerular basement membrane antibodies, complement levels, or cryoglobulins. 24-hour urine is the best way to test, as we know, for proteinuria. Other diagnostic tests include renal ultrasound, CT, retrograde pyelogram, cystoscopy, and a renal biopsy. We know that the main challenge is trying to figure out what the underlying cause is. So it's important that we get a thorough history and physical when you're assessing the patient, and then choosing the appropriate lab studies that will help lead to diagnosis. And also, the patient's history can provide much information indicating if there's been issues with poor renal function or systemic perfusion prior to this injury. If you are concerned for pre-renal etiology, your patient may present with dry mucous membranes, decreased skin turgor, reduced JVP, hypotension, oliguria, and weight loss. In the intrarenal etiology, this can occur due to antineoplastic agents, anesthetics, antimicrobials, a variety of different medicines. We know that the inflammatory process related to infection and toxemia of pregnancy can lead to intrarenal etiology, and then immune processes such as those with autoimmunity issues, hypersensitivities issues, or those that have had a tissue or organ transplant rejection medications can lead to an intrarenal etiology. Also, trauma and radiation can do this to the kidney if there's an obstruction. If there's any intravascular hemolysis going on after a blood transfusion, it can impact the kidney in an intrarenal manner. You may see intrarenal etiologies with systemic and vascular disorders, and then also with some pregnancy-related issues. In your postrenal etiology, it results from the interference of blood flow through the kidney, and this could be associated with an obstruction or disruption of the urinary tract. So a history is very important to determine if there has been an obstruction, and physical assessment findings need to correlate with the lab and history findings. Further etiology, if there's been, for postrenal, if there's been a change in urine volume, if there's been prostatic disease or any abdominal neoplasm, any history of UTIs, pregnancy, abdominal surgeries, paralysis. In prerenal azotemia, the goal is restoration of the intravascular volume. You want to replace fluids. If GI fluid loss is generally hypotonic, it should be replaced as well. And if there is blood loss, then you'll want to give both fluids and pack cells. It's important to assess for fluids and electrolytes, because with these conditions you can have hyperkalemia, and this can lead to an emergent situation if not managed appropriately. And we know that elevated potassiums can cause electrocardio abnormalities. In the postrenal issues, you need to identify the level of obstruction, followed by the treatment to relieve the level of obstruction. So you may see your patient needing a percutaneous nephrostomy or ureteral stent placement. They also may need bladder catheterization or placement of suprapubic catheter to help relieve the obstruction. Okay, our next section is chronic renal failure, and this is our last topic that we're going to talk about. So we're right at 19 minutes, but we're going to push through until the end so we don't have to have a third video. So chronic renal failure is the progressive loss of the nephrons and their functioning ability, and it's going to eventually lead to end-stage renal disease, and it often arises as a complication of another systemic disease, and it can take anywhere from months to years to occur. Some of the causes of CRF, diabetes, and hypertension are responsible for about 70% of end-stage renal disease. Other underlying conditions, glomerular nephritis, cystic disease, and other urological diseases. Some of the risk factors include the use of analgesia, cigarette smoking, collagen vascular disease, AIDS-related nephropathies, cirrhosis, multiple myeloma, and then polycystic kidney disease. Under the pathophysiology, diabetic nephropathy is the most common cause, as we've talked about. So high blood sugars can lead to alterations in the tubuloglomerular feedback. There can be abnormalities in metabolism, and we know that with these elevated blood sugars, you can have a formation of AGEs, which are your advanced glycosylation end products, and these can collect in the tissues. Age peptides parallel the severity of the renal dysfunction. And ultimately, the glomerular cellular metabolism leads to changes in the hemodynamic changes in the kidneys. Hormonal imbalances can impact CRF, whether it be growth hormone or glucagons. They can produce a hyperfiltration in the kidney, and then renal hypodynamic changes. Those occur when there's circulating levels of vasoactive hormones, and then the body has an altered response to them, and this can lead to infiltration. So just briefly, a little bit about the patho of CRF. Elevated blood sugars, we know, can increase the intracellular fluid volume, which causes renal hypertrophy and alter the hormone action that increases pressure in the glomerular membrane. Increased blood sugar also increases the transglomerular protein filtration process. It increases proteinuria, and it also causes destruction of the nephrons and the glomerula and cause fibrous scars that does not allow the kidneys to function. When there's difficulty with this hyperfiltration system, then a compensatory hyperfiltration system is initiated, which further increases the GFR and causes more renal failure. There is also the hypertensive nephropathy, and it's the second most common cause of renal failure, and it's a resultant disease is also nephrosclerosis, but it's where the renal arteries become thickened while the lumens become more narrow, and there's a decrease in the renal flow, and all as a cause of hypertension. So signs and symptoms may vary depending on the renal injury, but you may notice proteinuria, nocturia, cast, and azotemia. Treatment is focused on controlling hypertension. And it's a vicious cycle, because if there's renal artery stenosis and then those vessels become thick and stiff, the body perceives a decrease in blood flow, and then the renin, angiotensin, aldosterone axis is activated, and then you can have anywhere from mild to severe hypertension as a result of the retention of the water and the sodium. With these individuals, it's important to auscultate for buoys in the flank or the mid-abdomen over the affected renal artery, and also to be aware of any elevated renin levels on the ipsilateral renal vein. Treatment may require angioplasty or a stent to be placed, along with medical management. So the third most common cause of CRF is glomerular nephritis, and it's an inflammatory process that affects the glomerular capillaries. So with nephritis, you can have glomerular inflammation and or necrosis, and nephrosis, you have abnormal permeability of the glomerular walls, and this can impact your serum protein. Symptoms may not occur until there's been significant renal impairment function, down by approximately 10 to 15%. Some early symptoms may include anorexia, fatigability, weakness. You also may notice uremia, where there is high levels of waste products in the blood system. With the waste products that are circulating throughout the blood, you may have dermatological abnormalities such as itchy skin, dry skin, and then there may be GI issues. You may notice anorexia, nausea and vomiting, and also hiccuping. Neurological symptoms may be emotional instability, depression, insomnia, fatigue, confusion, headaches, seizures, comas. Your patient may complain of a urine odor to the breath and perspiration. There may be shortness of air, metallic taste in the mouth, impotence, nocturia, foot drop, infection, bleeding, gout. The patient may appear pale. There also may be a uremic frost appearance to the skin. Or there can also be a hyperpigmentation. You can have bruising. There can be peripheral neuropathy, altered mental status, and swelling and ascites to the abdomen. When you listen to the lungs, you may notice crackles or a pericardial rub, elevated blood pressure, a rapid heartbeat, and there are also increase in the metabolites seen in the blood. And those blood studies that you would be doing would be your BUN creatinine, your creatinine clearance, and your creatinine can track the progression of chronic renal failure. The GFR can be estimated using the Cockcroft-Gault formula, and it's listed there below. But if you're needing more information on how to calculate that, likely some of your apps that are on your phone that you might use for medications can calculate it, and there's also free apps out there that you could add to your phone if that's something you needed to do frequently. Trends in GFR are more important than just the one-time isolated lab value, because they're going to tell you a little bit more about renal functioning and stability versus a single finding. Creatinine clearance is far more informative as a way of measuring renal function. And we know that when renal function declines further, the patient needs more continuous monitoring of labs to detect electrolyte imbalances and if there's any acidosis going on. So on testing your CBC, you may have some anemias going on and other blood cell issues related to the chronic renal failure. Your blood chemistries may show that there's decreased vitamin D, elevated ammonia, BUN, and creatinine, and elevated blood sugars. Your analysis may be used to determine if you have proteinuria. Ketoacidosis, we know, can artificially raise the creatinine level, and certain drugs can also alter diagnostic tests. And these drugs may include Tagamet and cefalozolin. You may want to complete a 24-hour urine study and then also check further labs. Renal ultrasounds are likely going to be performed at least as a baseline so that you have something to measure from. Sonography may reveal decreased kidney size, polycystic kidney disease, or an obstructive ureter or bladder outlet syndrome. A renal CT or a CT angiography may be performed, MRI, MRA, and then a duplex Doppler ultrasonography can help let you know more about your renal vascular flow. All right, management of these patients is primarily to determine and control what is the cause of the chronic renal failure. You're going to be monitoring their changes in renal function. You're also going to want to promote conservative treatment for the physiological effects of the chronic renal failure. More aggressive treatment will be led by your nephrologist, and that may include dialysis and or renal transplant. In these folks, it's important that their blood sugar and blood pressures be strictly controlled. And also, it's important that this group of patients be on at least an ACE inhibitor, as we know that it has nephrotoxic protective mechanisms. So even if you have your patient managed on other medications for their blood pressure, or that they don't have blood pressure issues, having them on a 2.5 or 5 milligram of an ACE like a lisinopril is going to help protect their kidneys. And if they can't tolerate an ACE, then to put them on an ARB. Further management may include percutaneous angioplasty or surgical revascularization of the artery with stenting. Dietary restrictions may be needed, such as fluid and sodium. The patient may need to monitor their protein intake, but it's important to get enough calories in the day. You may want to refer them to a nutritionist, and it's important also to monitor for dietary phosphates and potassiums and to decrease these in the diet, as they are more inclined to have an elevated potassium level. We talked about this previously, that they need to avoid vitamin D and calcium supplements. Vitamin E may be helpful in treating muscle cramps, and if your patient is having anemia and they versus having blood transfusions, they could be treated with erythropoietin, also known as Procrit, and it's important if they have anemia that you assess for their iron stores, because ferritin is going to be needed for blood production as well. It's also important to make sure that you are familiar with the medications that they are on and avoid any nephrotoxic agents. Keep the skin moisturized. There are several different products out there that could be used for pruritus. Use diuretics for use diuretics for edema, but it's important that you avoid dehydration. And then also potassium-sparing diuretics should not be used. If there's concerns that your patient is in metabolic acidosis, you can give them sodium bicarb twice a day. And then if your patient is having issues with fluid overload, hypertension, hyperkalemia, or infection, hospitalization would be warranted. If you have a GFR that's less than 10, a creatinine approaching 12, or a BUN greater than 100, more aggressive therapies are required, and these would be indicating dialysis, and you would likely be having your patient admitted and consulting a nephrologist. So progression of kidney failure is going to be dependent on the underlying type of kidney disease that it is, and then kidney disease is more rapid with those that have diabetic neuropathies or severe hypertension, and slower in patients that have polycystic kidney disease. Follow-up is very important so that you can be assessing underlying conditions that can lead to chronic renal failure. Patient education. They and the family need to know about how the disease is going to progress, treating all the underlying systemic conditions such as diabetes and hypertension, understanding the treatment plan, the importance of trying to avoid infection, maintaining a healthy diet, and knowing when and what to report. Sorry for that one being so long, but we are at the end of Chapter 12. Thank you.